Now let's move to a little forwards towards the lens now, having stayed in the macular area for a fairly long time. I'll be sharing some experience of cataract surgery and diabetic macular edema. As you know, cataract is one of the major causes of visual loss in diabetics, and the number of diabetics is increasing, likely to go to 333 million by 2025. And diabetics have a higher likelihood of cataract, and the risk is sometimes 15 to 20 times more in patients less than 40 years. 20% of all cataract surgery is performed in diabetic patients, and the risk of developing cataract increases with poor metabolic control and duration of diabetes mellitus. DME is one of the main causes of poor visual results after cataract surgery. And these patients undergoing phacoemulsification appear to have a doubling of the progression of diabetic retinopathy at the end of 1 year. The presence of cataract also interferes with the visual acuity, it interferes with adequate examination of the retina, and it also makes photocoagulation difficult. And the challenges are worsening of the macular edema, progression of the diabetic retinopathy, rarely anterior segment neovascularization, and both increased intra and post-operative complications of cataract surgery. As we all know that cataract surgery leads to a breakdown of the blood aqueous barrier, which is more severe in diabetic patients, and it's been reported that the VEGF levels in the aqueous, they peak 24 hours after the cataract surgery and they normalize in about 4 weeks' time. This information is important to plan the treatment in these cases. What should be broadly the approach in these patients? We have to focus on the preoperative workup, when to operate, the choice of the procedure, post-op care and follow-up, and then finally the role of vitrectomy and ILM peeling. The preoperative workup is important in these cases. This is the case who had been operated elsewhere, whose sugar was well controlled. He didn't give history of any laser earlier, and according to the patient, the fundus was not evaluated. The vision didn't improve after cataract surgery, and this is how the retina looked at 2 weeks after cataract surgery. So it's very important that all cataract surgeons should have a thorough evaluation of the posterior segment before the cataract surgery is done, especially in diabetic patients. And then when to operate. The intervention will depend upon the stage of diabetic retinopathy, the stage of diabetic macular edema, and the extent of the cataract. And based on this will be the priority whether you are going to treat the macula first or you are going to treat the cataract first. Now this is a case who had a good metabolic control, a visual acuity of 6/12 both eyes. This patient had a bilateral cataract surgery, both eyes within a span of 2 weeks. And post-operatively, the visual acuity came down to 636 in both the eyes, and there was worsening of the macular edema. This is the pre-Avastin era case. Now have a look at another case. This patient is 57 years old, had a cataract and a non-centered DME in both the eyes. The right eye had a pre-op Avastin and a phaco, and in the post-op period had a good improvement in vision, improving to 6/6 at 2 weeks, whereas the left eye, which had a cataract surgery alone, didn't have anti-VEGF. He had a worsening of the macular edema and visual acuity improving to 6/12 part. So the anti-VEGF definitely have a role in these cases, and then the cataract surgery should be done first, taking care of the foveal area. Now this is showing that the eyes with diabetic retinopathy without concurrent central involvement DME in the presence of non-central involvement DME immediately prior to cataract surgery or a history of DME treatment, these cases have an increased risk of developing central DME 16 weeks after cataract extraction. This means that your standard cataract surgery follow-up is day 1 and day 14, and after that we don't see those cases, maybe after 1 year. But when you're doing cataract surgery in diabetics, these cases need a closer follow-up, and it's important to see these cases at about 16 weeks or 4 months time and keep them on a closer follow-up so that they do not, so that to monitor any developing changes in the post-op period which can be identified and treated early. Now this is if the media is too hazy for carrying out the macular laser. These are the cases then where you give anti-VEGF pre-op, go ahead with the cataract surgery, and then go ahead with continue with your treatment of the DME in the post-op period as early as the media clarity permits. This is a case who had this is a patient who had Avastin 10 days before the surgery, and then the photocoagulation was done later on at 4 weeks, and the combination of a pre-op anti-VEGF and a post-op laser gives you the best chance of maintaining the visual acuity in these cases. This is a case whose first presentation had a visual acuity of 612, had an early cataract, had a non-center DME. Patient was advised laser, but the patient refused to get it done. Patient comes back 2 years later, the visual acuity has reduced to 636. He is advised intravitreal injection, but there is no response to this injection. 2 injections and still there was no response. These are the cases where you will need intravitreal steroids. We gave injection Ozurdex, and the visual acuity improved, and this is now the time this patient should go ahead with the cataract surgery. So in those cases, before cataract surgery, it is important to control the DME and then go ahead with the cataract surgery so that you do not land up with cases with poor visual acuity post-op. Now this case, we repeated Ozurdex after surgery. Now this is the case showing fluorescein angiography. The visual acuity improved to 6.9 day 1, and 4 weeks post-phaco, you can see that things are much better. So consider Ozurdex in patients with DME when Avastin fails and effective laser is not possible due to the cataract. Consider cataract surgery under the cover of Ozurdex followed by effective macular laser. There is a study showing that if you don't want to give intra-op, you don't want to give pre-op, you can give an intra-op VEGF injection also, because the peak of the VEGF appears at 24 hours, and by that time you have the anti-VEGF already in the vitreous. This is the case with 636 vision who had a pre-op Avastin followed by macular laser. 4 months later, the visual acuity was still down, and this is he went pre-op Avastin and his vision improved at 6 months time. So please consider cataract surgery under the cover of anti-VEGF agents if effective laser is not possible, and follow it up with an early macular laser. This is a 60-year-old patient, and when we do fluorescein angiography, we find that the patient has a ischemic area. The foveal avascular zone is enlarged. Now these are the patients where we know that in spite of the best treatment, the final visual acuity is not going to be normal. These are the cases where you need to give them a realistic preoperative counseling about the visual outcome after cataract surgery. Now patients who are going ahead with the cataract surgery, they may have different situations. Patient may have a non-centered DME where you will do a laser or a focal laser or a micropulse laser, and you may consider giving intraoperative anti-VEGF in these cases. The cases who have a central involved DME, they will need anti-VEGF or steroids, and they need a prompt or deferred laser treatment depending upon the media clarity. The case who has a recurrent DME will need a supplement of the laser, reassessment, and then anti-VEGF or steroids. Patients who have a chronic DME definitely will need an intravitreal implant or steroids. Patients who have been treated with DME, if it is well lasered, go ahead with the cataract surgery with realistic expectations, and close follow-up on these cases is important. And if it is an ischemic DME, depending upon the grade of the cataract, take the call for the surgery. So closed follow-up in these cases is important. This is the case where micropulse laser was done, and then cataract surgery was done 3 months later. And this is the case where focal laser was done and cataract surgery was done 3 months later. As far as the choice of the procedure is concerned, you should have a good macular control and make sure the diabetic retinopathy is stable. Of course, the cataract surgery should be least traumatic. A single piece aspheric hydrophobic lens should be the choice, and the femtosecond laser cataract surgery will definitely reduce the phaco time and the phaco energy used. Therefore, theoretically reducing the chances of effect on the DME. The Nepafinac has some role in the post-op period, should be used in all these cases. Now it is important to identify pre-op problem. It should not be missed. It should be treated according to the protocols. Very judicially decide the timing of the surgery. Surgical etiquettes and decisions to be maintained. Post-op management and close follow-up is required. Don't lose the track of these patients in the post-op period. And last but not the least, a good systemic control is mandatory both in pre-operative or post-operative area. So don't let the sun set forever on your diabetic patients. Thank you.